Okay, well, so this afternoon I'm tasked to talk about the variants that we've seen over the pandemic and vaccine effectiveness. Let me just remind everyone of what the recently approved vaccines are. They are different types of vaccines. So, for example, inactivated whole virus, and the Sinopharm Chinese vaccine is a good example of this, which is a more traditional technology in terms of producing vaccines. Then the more modern, if you like, or newer technologies. So, for example, the so-called mRNA vaccines, as exemplified by Pfizer and Moderna, and the adenovirus vector vaccines, for example, the Oxford AstraZeneca, the J&J, and the Sputnik vaccines are all based on adenovirus vectors. Now, it's important to remember, and throughout my talk, that all of these vaccines are based on the original SARS-CoV-2 virus that was seen in the original early outbreak from early 2020. Now, what do these vaccines do? Well, the whole inactivated virus vaccines presents multiple viral antigens to the immune system, to our immune system. So then our immune system will mount a whole myriad of responses to these pieces of the virus. The mRNA and adenovirus vaccines ultimately present just the virus so-called spike protein, which is, and I'll show you more detail in a minute, which is the protein that sticks out from on the surface of the virus particle. So it's a very specific immunogen, and the resulting neutralizing antibodies that are produced and T-cell responses will disrupt virus binding to cells and mediate destruction of infected cells. It's important as well to realize what the anticipated immunity will be from these sorts of vaccines. So what I'm showing here is a publication from Nature last year, showing what happens in terms of immunity in different stages of infection or with different types of vaccination. So during natural infection, and of course the virus infects the nasopharyngeal cavities, so through the mouth and nose, and infects cells there, and then will later on can invade into the lungs. So what happens in terms of immune response during natural infection is that in the upper respiratory tract, the response is mainly secretory IgA antibodies, which is surface antibodies. And in the lungs, this is mainly IgG, soluble IgG. So the IgA is really the first port of call to stop an infectious agent like a virus from taking hold in the respiratory tract. And the IgG really protects against lung disease. So all of the vaccines that we have are intramuscular vaccinations, and they currently protect against serious disease, but not infection, because they will induce IgG to protect the lungs, but won't induce any secretory IgA to protect from initial infection in the upper respiratory tract. We actually would require some sort of attenuated or inactivated intranasal vaccination, similar to some of the current flu vaccinations, to actually stimulate IgA responses to try and prevent infection altogether. So moving on to the variants, what are the variants and how do they arise? Well, the natural host of this virus, this coronavirus, SARS-CoV-2, is most likely bats and not humans. And with that in mind, once the virus has started to infect humans, variants with genetic differences to the original strain have evolved through a process of natural selection. And this is really just by random mistakes that are made during the genomic replication process, and can result in fitter, more prolific viruses. So greater fitness is due to increased infectivity, immune evasion, or both. And this has enabled the original non-human strain to adapt to humans in the population and spread better within the population. So really this is kind of a natural adaptation and Darwinian evolution. And nothing, I mean, even though the variants seem to be quite a sinister type of occurrence with this virus, it's something that really could have been anticipated because the virus has just been adapting naturally to replicate better and to evade the immune system within the human population. If we move on to some of the more basic science and what's happening with the virus when it infects cells, here's the virus particle, or the kind of cartoon of the virus particle, showing these spikes or S protein sticking out from the virion. And these are what latch onto the human cells, to our cells in the upper respiratory tract. And they do this is a molecular depiction of it. They do this by latching specifically onto a protein called ACE2 receptor. This is a publication from Nature last year that shows that structure. And what's interesting about this, and what's very informative about this, is it shows where the interactions actually are between the virus spike protein and the ACE2 receptor. And it shows areas, so for example, this RBM, which is receptor binding motif, and other parts of the molecule that are very important with it in terms of this interaction. So you would anticipate that this would be important in terms of variation with the virus variants that we see. And in fact, that's the case. So we see mutations within this S protein that impact on infectivity and vaccine efficacy. So the S protein mutations can increase receptor binding, so they increase affinity for this natural receptor on our cells, the ACE2 receptor, by mutation in these areas around the receptor binding domain and motif. And also they can decrease antibody binding, so they can help to evade our immune system, which again is a natural process of survival of the virus in our system. And this is via various mutations, again, within this area that interacts with the ACE2 receptor. So these areas are important both in terms of interaction with the receptor and interaction with neutralizing antibodies. This is a very busy slide, but I'm just going to make a point that when we've studied the variants from different geographical locations all around the world, certain patterns have started to arise. And I just want to focus on two parts. This is the S protein, the spike protein here, a molecular depiction of it, showing the receptor binding motif, which binds, as I just said, to the ACE2 receptor and is targeted by neutralizing antibodies. And also another site here, which is the N-terminal domain supersite, which is targeted by some neutralizing antibodies as well. Important sites on the virus protein. Now, when we look at variants and look at just maps of where where the mutations occur in this protein, they are in fact all clustered around the receptor binding motif. So this is in the red here. You could see this gives a list of various different variants from different countries, etc., and shows with these lines all mutations within these variants. So you can see a cluster in this small area here, which equates to this part at the top of the molecule. And also in the N-terminal domain supersite, which is actually spread out on the linear polyprotein of the S protein, but all come together when the protein is folded together. But again, you can see clusters of mutations within this yellow, which is the N-terminal domain supersite, which shows that these are really important areas of the protein for both infectivity and evading the immune response. This is a list of the most significant variants of concern that we all know and we've been talking about for quite a while now, the alpha, beta, gamma, and delta. They had different kind of names depending on which lineage they came from, and obviously they came from different countries. How they all have their own unique mutations, and some mutations are in common. Some of these have impacts on transmissibility of the virus, and some have impacts on immunity. And let me just go through these a bit slowly in turn. So starting with alpha, the alpha variant, this emerged in southern England in around September last year. It was first found. It seems to have a significant replication advantage by virtue of certain mutations in S. So for example, the 501Y mutation. And this virus seems to be able to replicate 40 to 70% better, or it's more infectious than the original strain that was first isolated and seen back in early or late 2019, early 2020. There's an interesting deletion of a couple of residues, 69 and 70 in the spike domain, spike protein, which may impact on replication, may enhance replication. And just by a quirk of this, the way that the PCR assay or some of the PCR assays to detect the virus were being carried out, because of this deletion, it caused a so-called S gene target failure. So these viruses with these deletions failed in a certain part of the PCR assay. And this became a signature fingerprint of this virus and enabled very rapid detection and really mapping of the spread, incidence and spread of this variant in the UK over the end of last year and the beginning of this year. This variant of these mutations seem to have very little impact on vaccine efficacy. And as I said, it spread very rapidly in the UK and around the world towards the end of last year and the beginning of this year. And it was first actually seen in Barbados late in December 2020, when there was a big spike of infection, and early in January 2021. Moving on to the beta variant, this emerged in South Africa around September 2020. It has a significant replication advantage over the original strain, again by virtue of the 501Y mutation in S. And it also has some interesting mutations that seem to have an important impact on vaccine efficacy, particularly around the 400 residues, 484 and 417 in the S protein. So this is an example of a variant that can replicate faster than the original, and also seems to have an ability to evade the immune response to a certain degree. This is borne out when vaccine trials were studied in South Africa. So vaccines were all significantly less effective at preventing disease during the trials when beta was the dominant variant in the population. So for example, AstraZeneca was only 22% effective, the J&J 56%, and then Novavax was 60% effective in these populations with beta as the dominant variant. So you can see that by virtue of these mutations in the spike protein, these vaccines were less effective at preventing disease. The South African variant towards the end of last year spread rapidly in South Africa and seeded around the world, but interestingly hasn't really become a dominant variant anywhere else in the world. Moving on to the gamma variant, this emerged in Brazil in December 2020. Again, has the same 501Y mutation, so you can see this pattern emerging over and over again, even though these variants were first occurred in different geographical locations in the world. And also it has similar mutations to the beta variant in S protein, which has an effect on vaccine efficacy and evasion of immune response. And again, this spread rapidly in Brazil at this time and seeded around the world because of travelers and traveling around the world, but it hasn't become dominant. And it has been reported in Barbados in mid-2021, although I'm not sure whether that was from importation in visitors or returning nationals, or actually in the community. Now, the Delta variant has become a really important variant in the world now. It first emerged in India in around December 2020, alongside two siblings, if you like, or related variants with related changes or mutations in the S protein. But this one really became very dominant. It has a significant replication advantage over actually all of the other variants and the original strain, although the specific mutations that confer this advantage are kind of unclear at the moment. It's highly infectious. It causes a high level of viral load in people who are infected, up to 1,000 times more than some of the other variants. Replicates faster than alpha, around about 70% faster. And so you can see why this really has spread very quickly, because it really is a very highly infectious variant. There's some impact on vaccine efficacy, probably by virtue of a couple of mutations, again in the 400s, in the S protein 425 and 478, and possibly other mutations as well. And there's a kind of a variation of this variant that is known as Delta Plus, that has an additional 400 spike mutation, the 417, which is actually seen in the beta and the gamma variants as well. So putting all this together, it's a really quite a nasty mix of variant that's able to replicate very quickly, is highly infectious, and it can evade the immune system and has these mutations have an impact on vaccine efficacy. This spread rapidly in India from the end of last year and through the first part of this year, seeded around the world and seeded into the UK very quickly. It actually first appeared in the UK around April 2021 and is now seems to be the dominant strain or variant worldwide. And it has been reported in Barbados in mid-2021, although again, it's not clear to me whether this is from just imported visitors or travelers, or is actually in the community, spreading in the community at the moment. But I've just taken a couple of graphs from some publications by Public Health England. This is from June this year, showing really dramatically how these variants in the populations of these variants can change very quickly. This is a long time frame from September last year through to June this year, showing the eventual decline of the original strain, original infection in the UK, the rise of alpha, and this was mainly detected by S-probe failures, or the PCR test. And then towards I guess, middle of April, the decline of alpha and the rise of delta. And this phase in more detail is really quite dramatic. This decline in alpha and rise in delta occurred within about 5 to 6 weeks in the spring of this year in the UK. So in mid-April, there was virtually no delta seen at all. By the end of May, this had taken over the whole of the population, if you like, of virus that was seen in infected people, and is now virtually 100%, and has been for a while actually, of all of the virus that's isolated from infected people in the UK. And it is fast becoming the same throughout the world. So you could see that this gives a very clear demonstration, indication of how infectious and how Delta is, and how it can spread very, very quickly in a population. In this case, in quite a large country, England, well, the UK. The Public Health England have also done done studies on the vaccine effectiveness, and this is with the vaccines that have been given in the UK, the AstraZeneca and Pfizer mainly, and looking at the effect on symptomatic disease and hospitalization. And remember that these vaccines were designed to prevent disease, hospitalization, severe infections and deaths. They weren't really designed to prevent infections themselves. So if you look at vaccination status of 1 dose or 2 doses of vaccine, this is either AstraZeneca or Pfizer. These are numbers where they're mixed together. And the effectiveness of the vaccine when people were infected with the alpha variant, after 1 dose, it was about 50% effectiveness and about 89% effectiveness at preventing disease if you were infected with alpha. But with delta, after 1 dose, about 35% effectiveness and getting on for 80% effectiveness at preventing disease if you're infected with delta. This led the UK government to try and really accelerate the phase of vaccinations in the country, from particularly people who just had 1 dose to accelerate those doses to get those people vaccinated with a 2nd dose, because of this gulf, this big difference in the effectiveness of the vaccines when people are infected with delta. The picture with hospitalization and severe disease is a bit different, luckily, I guess. With 1 dose, the effectiveness of the vaccines, whether you're infected with alpha or delta, seems to be the same, around about 80%. And with 2 doses, it's around about the same, in the sort of mid 90% in terms of protection against hospitalization, severe disease and death. There's a couple of things I want to say just about delta and its infectiousness. These are very recent data from Public Health England, again, just earlier this month, showing, if you just concentrate on this part of the graph with delta, there are 3 lines here showing people who are unvaccinated, vaccinated with 1 dose of vaccine, or vaccinated with 2 doses of vaccine. And what this scale shows is basically results from PCR detection assays and showing so-called CT values, which are values which give an indication of how much virus these people are infected with. And the lower the value, the more virus there is there. So essentially what this picture is showing is that, and now this is becoming common and has been repeated in other countries, that when people are infected with delta, whether they're vaccinated or not, they harbor very large doses of virus. So the vaccine itself is not necessarily stopping people becoming infected with large amounts of virus. And this is another very recent study. This is a preprint from a study in Singapore where mRNA vaccines have been used, and showing basically the virus titer, again with CT values from PCR tests, and days of illness with people who are vaccinated or unvaccinated. And so there are two interesting things from this, the messages from this graph. One is that whether you're vaccinated or unvaccinated, if you're infected, you tend to harbor a high titer of virus, and these CTs are around about 20, so this is very high titer virus. But as time goes on with days of illness, these levels are pretty similar from around about to day 5, 6. But then after about a week, there seems to be some divergence in these curves. So unvaccinated people seem to harbor infectious virus for longer, and this is right out to 28 days, whereas, or certainly PCR detectable virus, whereas in vaccinated people, these are vaccine breakthroughs, this seems to be, the virus seems to be disappearing quite quicker. Just want to say a couple of things about Lambda. I mean, Lambda is not a variant of concern yet, but it's certainly something that is being kept a close eye on. This emerged in South America, I should say, last year, has mutations again in the receptor binding domain, and in the internal domain as well. It has a very interesting mutation in this domain here, which is a 7 amino acid deletion, which seems to have a very strong impact on immune evasion. So to be able to evade the vaccines. It also has mutations here in the receptor binding domain that seems to make it highly infectious. So this is a potentially dangerous variant. And so in my opinion, vigilance is really required to keep an eye out for spread of this variant. This is a very recent preprint publication. So to summarize all of that information, the variants, the coronavirus variants have emerged due to natural selection and adaptation in humans, and convergent evolution of these mutations that the variants has been observed. The S protein mutations can increase the infectivity of variants and enhance immune escape, or both. And current vaccines prevent serious illness in people infected with variants, particularly after 2 doses, but not really 1 dose with the Delta variant. High virus titer is seen in Delta vaccine breakthroughs, but levels might decline faster than unvaccinated, but these are kind of preliminary data. And I think it's clear that partially immune populations with circulating variants are potential breeding grounds for vaccine-resistant variants that may emerge in the future. So just finally, what considerations are currently and for the future? Firstly, I would say that continuous and extensive genomic monitoring, sequencing essentially, is really essential in countries to track the development of existing and potentially new variants, because we really want to know if our vaccines are working or how well they're going to work. We need to monitor vaccine effectiveness and escape, and this again is very important as an ongoing exercise. And as immunity wanes, booster vaccines will likely be needed. And this might be via heterologous dosing. So if someone has received 2 doses of AstraZeneca, for example, then the 3rd dose, the booster dose, might be Pfizer. And new variant-specific vaccines are in development, certainly by some of the companies and the research institutes. And these may be more effective than current vaccines. So for example, a Delta-specific vaccine would be very useful now and I think in the future. And finally, intranasal vaccines could be the key to preventing virus spread and actually achieving true herd immunity. I think without these sort of vaccines, we'll probably never see herd immunity. And a final thought, the race between immune control and escape variants continues. Thanks very much.
Thank you very much, Dr. Larder, for a very insightful presentation. I know that you are hours ahead of us, and I know that you are quite a busy person, so I just want to say thank you so much. I'm going to hand over to Dr. Whitney Best for questions.
Thank you, Dr. Larder. We have at least 4 questions for you, so we'll see how quickly we can get through these.
Okay.
First is, to what extent do vaccinated patients spread the Delta variant?
Yeah, that's a very good question. And I think to answer that properly, we would really have to test extensively, particularly vaccinated people who showed no symptoms at all. And that's not really being done. So it's very hard to answer the question. My guess is that people who are infected with Delta and are vaccinated, from the most recent data that I've shown, will potentially harbor very high titers of virus in their upper respiratory tract. And so really would be, you would expect that they or anticipate that they would be able to spread the virus as easily as unvaccinated people. So we need to know whether Delta's around, and we need to really have an idea about who is being infected, particularly vaccinated people.
Thank you. Do you have information on the method of the development of the Cuban vaccine?
I'm not sure. I think it's a inactivated whole vaccine. Or is it inactivated whole vaccine? I'm not really sure. I can't really answer that one. Sorry.
Okay. From Professor Waldron, why are we not advocating for both nasal and intramuscular vaccination? Is it that the nasal vaccine has not been developed? And if so, is anyone working on it?
I think there will be groups working on it. I mean, it's not as easy to do to produce, because so for example, with the flu vaccine, that's an intranasal vaccine, that's attenuated flu strains. Now to attenuated but live, because you want to see some virus replication. To do that with COVID, with the SARS-CoV-2, I think could be quite potentially hazardous. Although I think there is a new intranasal flu vaccine that's actually inactivated and it has some adjuvants that actually promotes the immune response. So that might be a way to go, an inactivated intranasal, and I'm sure that those types of vaccines are being worked on.
From Dr. Connell, is it reasonable to extrapolate that protection from severe diseases predominantly an IgG-mediated response from the current vaccines? What are some potential targets for antivirals? And I'm assuming this will be non-spike protein related. Yeah,
I think you're right. The first part of the question, I think the school of thought at the moment is yes, the protection from severe disease is predominantly IgG mediated and not necessarily T-cell mediated. Some potential targets. The coronavirus has a unique, I think more than one protease, and RNA polymerases. So I think, as with say HIV, for example, the protease, unique protease of HIV was a very rich target for antivirals, and that could be the case with SARS-CoV-2. The problem with antivirals, with any respiratory virus like rhinoviruses, flu viruses, colds, etc., is the infection time frame. These antivirals would have to be administered very quickly after someone became infected, before the infection took hold. With other antiretrovirals, that doesn't need to be the case, because virus can be suppressed during a long phase of infection with HIV. And so it's been quite difficult with a number of respiratory viruses, including the coronaviruses, to produce antivirals that are effective, mainly because of the time frame in terms of when they need to be taken.
Thank you. So one more question, and then I'll invite you to please type your answer to the others remaining in the Q&A section. Do high viral loads in vaccinated persons mean that they're involved in viral transmission? And how much effort should Barbados put into discovering which variants are circulating in the community?
So yes, it is anticipated that because of the high viral loads with Delta infection, that people will be spreading, particularly that virus, even if they're vaccinated. And in terms of effort, I think there should be more than 100% effort put into discovering what variants are circulating on an ongoing basis, actually. And I kind of disagree with a comment that it's not really fair to disagree with him, but that Dr. Ford made about doing the testing in the country versus not relying on external testing all the time. I think particularly with small countries, it's probably a better use of resource to actually batch test on a regular basis externally, rather than set up, so actually send samples to large sequencing and genotyping organizations, rather than spending a lot of time and effort and money and personnel on setting up all of that infrastructure, etc., in a small country. That's just my bias on that. But however you do it, you need to do it. And from what I can see, particularly in Barbados at the moment, that's not really being done in a timely manner and in a way it should be. But for example, from a quick calculation and looking at one of Dr. Ford's slides, in July there were about 360 or more than 360 cases. How many of those have been tested for? So how many of those do we know are Delta, or what variants are they? Have any of them been tested? And is there a program to test them in an ongoing way? I mean, I really don't know. And I'd have thought that with those sort of significant numbers, that they really, at least 10% or 20% should be tested on a regular basis.
Well, thank you so much, Dr. Larder. I'll ask that you can look in the Q&A and type your answer to our other attendees' questions, and we will hand back over to Dr. Grandison.
Thank you very much, Dr. Whitney-Best. Our next presenter is Dr. Chris Nichols. His presentation this evening is entitled Thromboembolic Disease with COVID-19 Vaccines. Dr. Nichols has earned a biochemistry and physiology degree from Leeds University, when he subsequently went on to undertake his MBBS degree at the University of the West Indies. Following that, he underwent a Master's of Science in Oncology at Nottingham University, and then subsequently sat for his MRCP with the Royal College of Pathologists. He has also undertook a certificate in transfusion science and British Blood Transfusion Society. He is a consultant at the Queen Elizabeth Hospital in the Department of Pathology as a hematologist. He also works privately at the Barbados Reference Laboratory. Good evening and welcome, Dr. Nichols.
Hello, good evening. Can everyone hear me? Hello, good evening.
Yes, please, we can hear you.
Yeah. All right, good evening. Well, first of all, thank you for the organizers for inviting me to join this CME event. Okay, can you put up my slides?
Yes, could you, your sound is a little low, so I will share your screen in the meantime. Could just check the microphone, please.
Yeah, sure. Okay. All right, am I coming through a bit clearer now?
Yes.
Okay, all right. So my topic is really dealing with the hematological complications of the COVID-19 vaccines. Now, because of the nature of the pandemic, the production of multiple vaccines against COVID has occurred in an unprecedented time frame previously unseen with regard to development of vaccines. Now, the most common vaccine subtypes that we see in this side of the world are the mRNA variety, which Dr. Larder went through, the adenoviral vectors variety, which we are more au fait with here, which is the Oxford AstraZeneca, which came out of the UK, and then the Johnson & Johnson variety present in the US. And then then we have the inactivated COVID-19 virus Sinopharm from out of China. All right, next slide. Now with the mechanism of action, the modified mRNA encodes a mutated form of the spike protein of COVID-19. And in Dr. Larder's lecture, you've seen that this is essential for the COVID-19 virus to actually penetrate human tissue cells. And for the Pfizer and Moderna type, they involve encoding or presenting a mutated form of that protein, which is presented on the cell surface of the human tissues, and then that is what triggers an immune response in recipients. For the adenoviral type of vaccines, both the Oxford AstraZeneca and the Johnson & Johnson involve using inactivated adenovirus as a vector for presenting the DNA coding sequence of the spike protein, which is then enters into the human tissue cells, which then make this altered S protein, which is then exported onto the cell surface, and then this stimulates both the B and T cells of the immune system. The slight difference between the AstraZeneca and the Johnson & Johnson is that the AstraZeneca uses a chimpanzee adenovirus, whereas Johnson & Johnson uses a modified human adenovirus. And the fact that you're using these adenoviral vectors could be a clue as to why these two particular viruses are associated with the hematological side effects, which have gained, quite amount of press coverage. All right, next slide. All right, so this is just a little cartoon of the coronavirus, and so where it shows the spike or S glycoprotein, that's what is utilized by the virus to actually penetrate tissue cells. Next slide. All right, and just briefly talking about the inactivated Sinopharm virus. This uses the intact COVID-19 virus as opposed to the previous mentioned vaccine types, but the actual genome or the replicating machinery of the COVID-19 virus has undergone chemical inhibition, similar to what was utilized to make the polio vaccine. Therefore, you have an intact virus or virus particle, but it is incapable of replicating. So the entire viral capsid is utilized to stimulate the immune response. All right, next slide. Okay, so the hematological complications are really now associated with, as I said, the AstraZeneca and the Johnson & Johnson vaccine types. The other vaccine types are not been reported to date as causing any significant hematological complications, but they themselves can cause certainly severe or significant allergic reactions. All right, next slide. All right, now these hematological complications have been given various terms. In the UK, it's been the terminology is a vaccine-induced immune thrombocytopenia and thrombosis. For the US, they have two variants of vaccine-induced thrombotic thrombocytopenia or thrombosis with thrombocytopenia syndrome. They're all can be used interchangeably, but most people are now, I think, going to utilize the abbreviation VITT. All right, next slide. Right, now 3 major international hematology societies have published position statements on VITT. ASH came out in just July of this year. That is the American Society of Hematology. They have come out with a position paper, or position statements, I should say. The British Society of Hematology in June, also this year, and their counterparts in Germany at the Society of Thrombosis and Hemostasis Research have also published position papers or certain guidelines. All right, next slide. Now, they have also that has come out in the first half of this year are certain, I would term them as pretty valuable papers in terms of clinical practice as it regards to these hematological complications. The New England Journal of Medicine, both in June and in August, just within the last week, published two very important papers regarding VITT. The Journal of Thrombosis and Hemostasis in April put out also a very good paper, and then also in Blood just last month also put out a very useful paper. All right, next slide. Reports of VITT started occurring in around the second half of March of this year, following the commencement of the adenoviral vaccines in the first week of March. And patients presented with a constellation of symptoms that reflected thrombosis, I should say, in both the venous and arterial systems. Next slide. And the most common sites of thrombosis seen were in the cerebral veins, the pulmonary and deep veins of the legs, portal and splanchnic veins, and then at the bottom, or less commonly seen, were thromboses in the adrenal, renal, limb vasculature, coronary vessels, and cerebral arteries. All right, next slide. And this is just a cartoon, just reminding us of the anatomy of the cerebral sinus venous system. Next slide. And another cartoon depicting the portal and splanchnic venous system. Next slide. Now, clinical complications or complaints, I should say, presentation could include severe headaches, visual changes, shortness of breath, abdominal pain, nausea, vomiting, back pain, leg pain. Next slide. Along leg pain and swelling and bleeding or bruising complications. And this latter, if it is seen, is of particular concern. All right, next slide. So patients who have been vaccinated and then present with any of these symptoms should have some routine basic laboratory investigations done. The first one is a full blood count of blood film, and this is to look at not only the platelet count performed by the analyzer, but what the actual platelet count is on the blood film. A full baseline coagulation screen, which is the prothrombin time, the partial thromboplastic time, and fibrinogen. Thirdly, a D-dimer. Fourth, what's called the antiplatelet factor 4 antibody screen, but that is a test that is really only performed at certain specialized laboratories, which those laboratories are not present in the Caribbean. And of course, some other, your routine baseline chemistry laboratory tests. I would just pause here for a moment regarding the baseline PT, PTT, and fibrinogen. Unfortunately, that even though it is classified as a baseline coagulation screening, historically, fibrinogen screening has not been something that has been done or included routinely here in Barbados. And getting D-dimers again is not something that is easily obtainable here in Barbados. And you'll see later in one of the later slides why that is the case. All right, next slide. And then appropriate radiological imaging, either by CT scan or MRI. Now, for patients who may present to QH, CT scan would be more easily obtainable, but most people are, or most of the guidelines or position statements are kind of advocating for MRI venography for those patients who are presenting with headaches, nausea and vomiting, and have a clinical suspicion of intracerebral thrombosis. All right, next slide. So the pathophysiology of VITT. This is considered now as an immune-based disorder triggered by the production of antibodies to platelet factor 4, which is released by the alpha granules in platelets. Next slide. So in this cartoon of platelets, on the left side is a inactivated platelet, and you can see where the alpha granules are labeled. And then on the right, that cartoon is trying to depict an activated platelet, where you can see some invaginations on the platelet membrane, and that is allowing where the granules can actually go up to the platelet membrane, make contact with it, and then secrete or release, I should say, their contents into the immediate surroundings of the platelet. Next slide. This cartoon is meant to depict this anti-platelet factor 4 action and how it promotes platelet aggregation. So platelets routinely or repeatedly will secrete platelet factor 4, and there's a similar immune-mediated condition called HIT, for heparin-induced thrombotic thrombocytopenia, and this depiction is thought to be a good model for what happens with VITT. So instead of heparin being present, an antibody triggered somehow by the adenoviral vector vaccines binds to platelet factor 4. This combination, this antibody platelet factor 4 complex, then binds to the platelet membrane, activates the platelets, causes cross-linking of the platelets as seen in section D, and then those activated platelets attach onto the vascular endothelium, triggering even further accumulation of platelets at those sites on the vascular endothelium. And so you can think of this process being extrapolated, and so you can get a quite large fall in platelet count as a result of an aggregation of a platelet mass occurring on the vascular endothelium, leading to thrombosis. And depending on the size of the vessels, you can see where blood supplies or vascular supply in acute areas, such as our CNS or pulmonary or splanchnic vasculature, where vascular compromise can occur. All right, next slide. So in VITT, as opposed to HITT, there is no prior exposure to heparin. So it's thought that there is an autoimmune antibody that has been developed within the individual that binds to the platelet factor 4 and attaches then to the platelet membrane, triggering the process that was depicted in the aforementioned slides. And therefore thrombosis then follows. All right, next slide. Now, why certain venous systems, such as the cerebral over arterial, and why some cerebral, why cerebral venous systems, let's say over the pulmonary or the splanchnic venous systems, those questions remain unanswered. So there's still significant gaps in our understanding of what the pathophysiology is behind this process. All right, next slide. Now, there are certain diagnostic criteria that have been generally agreed on both sides of the Atlantic between ASH and the BSH and their German counterparts regarding the diagnosis for VITT. And there are 5 criteria that need to be present for a definitive diagnosis. 1, the symptoms develop 5 to 30 days after vaccination against COVID-19 with either the AstraZeneca or Johnson & Johnson vaccine. 2, presence of thrombosis. 3, platelet count less than 150. So that means someone can have a platelet count of 110, which is not a too bad platelet count, but they could still be, a definitive case for VITT. So it's not the absolute platelet count, but it is the presence of a platelet count less than 150 that needs to be taken note of. A very high D-dimer level, greater than 4,000. Now, most commonly our internal medicine colleagues, when they're dealing with thromboses, they are not seeing D-dimer levels, usually do not see D-dimer levels in that range. So you have an extremely high activation of the coagulation system that is causing such a high D-dimer level. And then number 5, a positive screen for the antiplatelet factor 4 antibody. Next. Now there are then some other subcategories of VIT. So you have what's called a probable VITT, where there's still this very high D-dimer, but not all 5 criteria, or not all of the other remaining 4 criteria are present. You just need 1 of them to be absent and the other 3 to be present. And then you have a possible VITT where the D-dimer range is between 2 to 4,000, still quite high, but then you either have only 1 of the remaining criterion present or 2 being absent. And then the last category being unlikely VITT. So you can have a thrombocytopenia, but you don't have the thrombosis, and you have a D-dimer level less than 2,000. Or if thrombosis is present, there is no thrombocytopenia, that is a normal platelet count, and D-dimer again being less than 2,000. And interestingly, it has been included that in these patients, even if subsequent screening has shown that the antiplatelet factor 4 antibody was present, but the other parameters were not, so there was no thrombosis and there was no thrombocytopenia, then this was unlikely to be VITT. And in fact, it might just have been a false positive result for the antiplatelet 4 antibody screening test. All right, next slide. So to note, low platelets, low fibrinogen, high D-dimers were all associated with a poor outcome, and the risk or greater chance, I should say, of a poor outcome. And the risk of death is high, especially with a platelet count under 30, because there's a greater risk of intracranial hemorrhage. All right, next slide. So the treatment and management options for this syndrome. Now, once suspected, treatment should be initiated. So you should not really be waiting for this HIT assay, or that is the antiplatelet 4 antibody assay result. And the first step that should be given for these patients is initiating treatment with intravenous immunoglobulins. Now, intravenous immunoglobulins, this is an expensive medicinal product. It is not readily available in our setting. It is used to treat conditions of acute ITP, but as I said, it is not very readily available in the Caribbean. It is thought that IVIG blocks these immune complexes, of platelet factor 4 from then activating platelets, and to prevent that sort of thrombotic cascade from developing. Second therapeutic, or sorry, say treatment step, initiation of steroids. And this can be either from using either methylprednisolone, intravenous dexamethasone, especially when the platelet count is under 30. Thirdly, initiating anticoagulation with a non-heparin-based form of an anticoagulant. In the Caribbean setting, especially here in Barbados, that is going to be challenging. What is recommended are drugs such as argatroban, which is a direct thrombin inhibitor, fondaparinux, which is a semi type of, I would have to say, semi type of heparinoid type of compound. So it's not a fully heparin based product. Apixaban, brand named Eliquis, and the Bigatran, brand name Pradaxa. Next slide. Right. Followed by then plasmapheresis or plasma exchange. Now there's a bit of differing opinion from the expert hematologists on both sides of the Atlantic. In the USA, they are less keen on utilizing plasma exchange because they are concerned that you may not get enough removal of these antibody complexes, and there can be a greater risk of bleeding from you having to place in patients what we call femoral catheters for this procedure. Now, briefly, what plasma exchange involves, it means hooking a patient up to a machine that is going to extract their blood into a machine that separates off the plasma from their blood and then returns the returning solution back into the patient. The machine that would perform this type of procedure is not too dissimilar to the dialysis machines that the kidney units would utilize. But plasmapheresis is recognized to have treatment, or to be quite efficacious in treating similarly immune-mediated thrombotic symptoms. One of them being something called TTP, or for thrombotic thrombocytopenic purpura, which can be a very fatal disease if not acted on quickly. And of course, sometimes it can be plasma exchange can be utilized in patients with HIT, or in severe cases of patients with HIT. What is needed to make the plasma exchange or plasmapheresis successful is adding in a artificial plasma product that is deficient in certain naturally found plasma components that enhance coagulation. So you're sort of utilizing a deficient solution to help to try to remove these immune complexes from the person's vascular system to sort of slow down or turn off this immune-mediated process. In the UK, there's a greater advocate for utilization of plasma exchange, and in the article in New England Journal of Medicine of this month, author Pavert and L, they reported a 90% survival rate in 17% of patients who had VITT, in 17 patients, sorry, who had VITT, who underwent plasma exchange. Now, 17 patients, of course, that is a small number for which to base a certain clinical position, but this, as you will see in later slides, VITT is pretty uncommon but fatal, syndrome that does occur. All right, next slide. Continuing the management, any aspirin, I would extend any non-steroidal anti-inflammatory needs to be avoided. And also, of course, no warfarin should be utilized in these patients. And then lastly, platelet transfusion should be avoided unless absolutely necessary. And that is whether there's any acute bleeding, especially for any intracerebral events, or any invasive neurological procedures are used or needed to be required. In the position papers, they have quoted cases where neurological radiation neurological interventional radiologists were able to actually access the cerebral sinus venous systems to actually remove clots or from affected areas. So judicious use, or before consideration, I should say, of any platelet transfusions in these cases, consultation with your local hematologist is a must. Next slide. Now, Barbados situation. And the reason I put this slide in is to highlight I would have to say, the severe deficiency that exists in our main general hospital on the island. Regrettably, our hospital does not have a functioning coagulometer for well over a year. So we are in the midst of a global pandemic where vaccination is a necessity, and then you're going to have there's a clear but rare incident where patients can present with this condition VITT, and your local general hospital cannot perform on-site basic coagulation analysis. And I have to be blunt, that is clearly unacceptable. What has to happen now, presently, is that samples have to be sent out to private labs. But if patients present late at night or in early morning, you have delay in getting results. Therefore, you will not be in a position, our colleagues in the emergency room or in internal medicine or in intensive care will not be in a position to act appropriately for these type of patients. IVIG, as I was mentioning earlier, not readily available. This is an expensive product, this artificial immunoglobulin product. The local agents, Armstrong Healthcare, do not always stock it because the cost of this product can be upwards of $2,500 US for a dose of it per patient. Now, a dose can last for either 24 or for 48 hours. So you can clearly see we are dealing with significant costs for dealing with trying to salvage patients with this potential issue. Thirdly, the additional non-heparin-based anticoagulants such as argatroban and fondaparinux, not available at QAH. Apixaban or Eliquis is available locally, but not widely available. Dabigatran or Pradaxa, or otherwise known as Pradaxa, is available at our local hospital. In terms of the plasma exchange, this is best done with a product or an artificial product called Octoplas, and this was this artificial solution that I was describing earlier. But unfortunately, again, this is not available locally. Next slide. So given what I discussed, on the positive side, VIT is a very rare condition. The incidence can range from between 1 in 50,000 to 1 in 100,000 individuals. In the UK, between March and June of this year, they had administered at least 16 million doses of their AstraZeneca vaccine. And in that time frame, they were able to identify most likely 220 cases. So it is, so for 16 million administrations to be able to pick out about 220 is indicating that it is a very rare, condition, but needs to be recognized as quickly as possible. Also of note, there was no gender bias, according to latest articles, both from the New England Journal of Medicine and at ASH, etc. One may recall earlier in the year when these reports started coming through, it was felt that young women, especially under 40, were at a greater risk of developing these type of unusual thrombotic episodes following vaccination. But subsequent prospective cohorts have sort of laid that gender bias fear to rest. What is of note, however, that it tends to occur more commonly in the under 50 populations. And then, of course, lastly, what must be reiterated, and I think this goes back to what Dr. Corey Ford was talking about regarding vaccine hesitancy. Both the benefits of the AstraZeneca and the Johnson & Johnson vaccine far outweigh the risk of us individual developing VITT. But I can personally attest that when patients and I would have to say members of the nursing staff and other members of staff at QH have approached me, what they ask about when, especially with regards to the AstraZeneca or their hesitancy regarding AstraZeneca, is this fear of getting a blood clot. And this is unfortunately the consequence of the high publicity that was given earlier in the year to these instances. And as Corey has indicated, what we really are going to need is ongoing education, especially to our nursing colleagues, of the need for them to get vaccinated as quickly as possible. And last slide. And these are the references that I recommend anyone to go, to take their time and go through. Thank you very much.
Thank you very much, Dr. Nichols. Very informative presentation. I am going to turn you over to Dr. Whitney Best for questions, given that we are running a bit behind schedule. Dr. Best?
Thank you. Thank you so much, Dr. Nichols. So I'll get right into it. We do have quite a few questions. The Accident and Emergency Department actually has a point of care D-dimer access as part of their risk stratification process. And thus, D-dimers are actually easily accessible here in Barbados, as well as the 24-hour polyclinics and urgent care facilities. So that was an attendee just giving some information for the audience.
My response to that is that D-dimer alone, as seen by the criteria that I listed, is insufficient. It's one of the important, it's an important part of the criteria, but we still need a full coagulation screen. And unfortunately, point of care systems do not give us a full baseline coagulation screen. So we're still, we're still going to be swinging in the wind, as we say.
From Dr. Fernand, do we have any confirmed cases of it in our population that you know of?
No, nothing has been reported so far. And I think that's simply because the incidence of which this condition is occurring, 1 in 50,000 to 1 in 100,000, because our population is small. And I think we've only gotten about 30% or reached about 30% vaccination so far. We probably have not vaccinated enough people before you start, reaching that trigger or that cutoff point for the incident level.
Why no mention or comparison of the Cuban vaccines, which is used in Cuba? Is there insufficient information, insufficient collaboration?
Yes. Sorry to cut you off. Yes.
Okay. So insufficient information and collaboration.
Insufficient information. The BSH and ASH, they would just be looking at Johnson & Johnson and AstraZeneca. For political reasons, American health authorities are not going to be looking at anything coming out of Cuba.
Okay. Where do we refer for assessment for the anti-PF4, as you have stated that the screening is not available locally?
Right. Those samples have to be shipped out through a private lab up to the US. And the only two private labs that are capable of doing that are the reference lab and chemistry, I believe.
Just a few more. Should in patients undergoing LMWH versus unfractionated heparin anticoagulation be routinely screened for HIT with serial platelet measures? And if so, baseline day 3?
Okay. For the development of HIT is usually referring to the use of unfractionated heparin in patients. With the advent of low molecular weight heparin, over 20 years ago, the incidence of HIT reduced significantly, didn't completely disappear. So my reply to that is that for general inpatient use, I don't see why you should be using unfractionated heparin over low molecular weight heparin. You get equally an efficacious, cover for the patient. I think it's more of a historical practice to use at times to use unfractionated heparin, but low molecular weight heparin, in my opinion, better, safer, less complication. Now, what can happen potentially in our setting is that a patient may present with VITT, not yet, recognized and started on low molecular weight heparin. But once the clinical the syndrome is then recognized, then the patient should be transferred across from the low molecular weight heparin as quickly as possible. And in our setting, it would be Pradaxa or Eliquis, assuming the patient can swallow. And then if the patient is not able to swallow, we are going to be in a bit of a tricky situation because some of the parenteral non-heparin-based anticoagulants, such as fondaparinux, and I think argatroban, are not available locally.
From Dr. Jolly, if a patient has a history of clotting, should you recommend vaccination?
We do all the time because it's so rare. So in patients in our anticoagulation clinic, when they ask me, say, yep, go and get vaccinated. Without hesitation, go and get vaccinated. Patients with sickle cell or those who have had other prothrombotic tendencies, go and get vaccinated. It's only a minority of patients who are on immunosuppressive therapy, so like chemotherapy combined with steroids and such, who are getting active treatment, that I have advised delay until that period of treatment is completed, and then they're off the immunosuppressive medication.
And from Professor Waldron, are there any other trigger events apart from vaccination?
You mean for VIT? I think he's probably referring to VITT. So far, that hasn't been recognized at this point in time.
So I'm going to do one more question and then we could go to our next speaker. We're running about half an hour behind time. I hope attendees will just stick with us for our last speaker. Dr. Alert is asking, what about Xarelto?
Good question. No, it was one of the omissions when I reviewed the position statements for ASH and the BSHs especially, and it was almost like a silent omission because they just don't mention Xarelto in the papers that have reviewed, and it's an open question or an unanswered question, I should say. You know, to be seen at a later episode, I guess. But yeah, not answered at this point in time.
Well, thank you very much, Dr. Nichols. I'm going to invite you to please look in the Q&A section and respond to the other 6 questions that are there. To just type the answer to the attendees.
Okay.
And our last presentation for this evening is by Dr. Leslie Rollock. Her presentation is entitled Dengue, a Local Update. Dr. Leslie Rollock is a medical graduate of the University of the West Indies, Mona, and holds a DM in family medicine from the University of the West Indies Cape Hill campus. Public health training was first undertaken at the University of Birmingham, UK, where an MPH was awarded, and at the University of the West Indies, Mona, for a Doctor of Public Health. With over 20 years of experience in clinical medicine and just over 10 years in public health medicine, Dr. Rollock presently works at the Ministry of Health, Barbados, as the Senior Medical Officer with responsibility for surveillance, infection control, and environmental management under the designation of Senior Medical Officer of Health. Good evening and welcome, Dr. Rollock. Dr. Rollock, we can't hear you. Just turn on your mic.
I just realized. Thank you. Good evening to all.
You're welcome.
For inviting me to update on dengue. I'd like to say good evening, and to the Governor General of Antigua, Sir Rodney Williams, if he's still with us, and esteemed colleagues. I will give an update on dengue from a public health perspective. And there we go. And try to I hope you can see the screen and you can see the presentation clearly.
Yes, we can.
Very good. So at the end of this presentation, which will be, as I said, from the public health perspective mostly, you will be aware of the global distribution of dengue virus disease. You'll be familiar with the patterns of dengue occurrence in Barbados, as we've seen so far, familiarized with the current national surveillance guidelines, the national testing protocols also, be aware or be able to state the syndromes associated with the dengue virus infection and the current guidelines of management of dengue virus infection. We'll just look over that quickly and then be able to state the measures to prevent community-acquired dengue virus disease. Now, in the world at large, from the 2017 Global Burden of Disease study, dengue is identified as the most common vector-borne disease in the world. And its occurrence is increasing. From 1990, 23.3 million occurrences were recognized. And this increased to 104.8 million in 2013. And attributed deaths also increased over that period from around 16,957 in 1990 to 40,000, almost 41,000 in 2017. And it continues to increase. So countries are reporting more, but also the number of cases are increasing. So there was an 8-fold rise in reports to the World Health Organization between 2000 and 2019. For this global burden of disease study, data for analysis was not present for many countries, including quite a few on the African continent. And that study recognized that the third highest disease burden is in the Caribbean, after the traditional places where dengue is believed to have started, South and Southeast Asia. From that study, the age standardized incidence rate per 100,000 population is highest in Barbados, followed by Dominica and Indonesia and India. And that may be partly due to better reporting and also relatively small population size. This disease is predominantly mosquito-borne. Over the life cycle of an infected mosquito, we remember that it's only the females that transmit because they're the ones that need a blood meal. So once a mosquito is infected, it can infect persons for 3 to 4 weeks while it is still alive. Our predominant vector in across the world, actually, the warmer parts of the world are Aedes aegypti, but we're getting increasing assistance from albopictus, Aedes albopictus, and there are a few other mosquito species, especially in the wild sylvatic cycles. In temperate countries, the influence of the albopictus is increasing. Transmission may also occur with asymptomatic infection. We recognize that for persons that become symptomatic, transmission occurs 2 days before the onset of the fever, and it can continue to occur 2 days after the fever resolves. So it's believed that even with asymptomatic infection, no fever occurs at all, that once a person is infected and the virus is increasing in their body, they have viremia, they will still be infectious. Mother-to-child vertical transmission has been recognized. There have been 1 or 2 reports of sexual transmission. Theoretically, it can be transferred also by blood transfusion. The virus is present in other body fluids, but it's unclear if it's infected from these sources, for example, from breast milk. In dengue high burden countries like Barbados, there is usually endemic disease with cyclical outbreaks, for example, every rainy season. This is believed for Aedes aegypti, especially because there are drought tolerant eggs, so they will stay in the atmosphere and wait until the rain falls. In Latin America and the Caribbean, we've recognized outbreaks, epidemics actually, every 2 to 5 years, which usually signals a new cohort of susceptible persons. And often the first sign is disease in the young age group, 9 to about 15. Severe disease, because asymptomatic would not be recognized. Dengue is present in tropical, subtropical, and warming temperate climates. And it is also recognized that the albopictus, which tolerates colder temperatures, cooler temperatures better than the aegypti, is a significant promoter or enhancer of dengue outbreaks in these countries. The ideal breeding temperatures, we are told, for Aedes aegypti are 24 to 28 degrees C. So persons in places where the air conditioning temperature is kept at 24 degrees, that's actually an ideal breeding temperature for Aedes aegypti if it gets into those surroundings. The outbreaks usually occur in urban and semi-urban areas because of the conditions, the containers, and also the presence of many hosts, blood meals in close proximity. There are 4 recognized serotypes of this flavivirus. This genus also contains the diseases Zika, yellow fever, Japanese encephalitis. There's another tick-borne encephalitis, and there may be more that may come to our attention, but these are the main ones. There were queries about a 5th serotype, but that's not confirmed at this time. All 4 serotypes have been identified in outbreaks in Barbados. This virus is a single-stranded enveloped RNA virus with structural proteins and some 7 non-structural proteins, which are helpful in the infecting process of cells. The non-structural protein, including NS1, which we use for diagnosis, is expressed only in the infected cell so that it can be used for infection to help diagnose infection, and it is also released in the serum of the infected person. In Barbados, all 4 serotypes were circulating in 2010. In 2013, when we had an outbreak, practically all of the years, you will see in the next slide, types 1, 2, and 4 were circulating, but most of the cases that were diagnosed were type 1. In 2016 was another outbreak here, was type 1. And 2020 and 2021, the cases that we've identified so far have been type 3. So in Barbados, as I said, dengue is endemic, punctuated by intermittent outbreaks. We'll just have to look at the numbers. Our outbreaks are usually bimodal, early in the year and late in the year. But you recognize from the number, from the colors, the first 2013, it seemed as if the whole year was an outbreak. When they had those 3, but mostly type 1. Then in 2014, it was outbreak towards the beginning of the year and then towards the end of the year as we expect. Similarly in 2016, but there was nothing much happening in 2015 with the onset, where you may remember we had the onset of the Zika outbreak, and 2017, where they were just the endemic levels. Then there was a latent period for dengue in 2018 and 2019. The next outbreak occurred towards the end of 2020. And we do continue to test. There is a protocol. We have been encouraging persons, if you suspect somebody has symptoms of dengue, not everyone necessarily, but you suspect somebody has dengue fever, take a blood sample, because that's the only way that we can actually, we can type the virus. So dengue outbreaks in Barbados are determined using case data, confirmed cases. We use the monthly case numbers and calculate 2 standard deviations about the mean. The average is the mean for the months, and you will see that expected from the average, we expect early in the year, January, February, around that time, and then later in the year, mid-October to November. Those are the times where we usually, historically, had higher numbers of cases, but in between the dryish seasons, even though there's water storage, we don't expect April, May, June, July, really, for anything to be happening. From the graph that is shown, we can see that from the green bars, that we actually had an outbreak in October, November 2020. We also collect information on suspected dengue cases. And because we use information on suspected cases are those that are clinically diagnosed, also those that are diagnosed by antibody tests for reasons which will be clear a little later. Up to the end of Epi Week 22, which is in June, 5th of June, early June, there had been 387 suspected or probable cases, and more than 100 of these occurred in Epi Week 1. We have an agreement with one of the private laboratories that when samples are sent there and they do the antibody test, that they will send them on to the public health laboratory so that we can perform the confirmatory testing on them. So in spite of the testing that would have been done on those samples sent on, we only had 3 or 4 confirmed samples, even though there were more than 100 in Epi Week 1 suspected cases. The confirmed cases for this year so far have been mostly around February, March, which is unusual. We've noted that we have delayed confirmation of cases because the mechanisms in the lab that are used to diagnose dengue by PCR, real-time PCR, the same resources, especially persons, are used for COVID confirmation. So up to the end of the early June, we've confirmed 133 cases, which by themselves would not have suggested that we were having an outbreak or anything. But when we plotted it by month, we recognize for 2021, the salmon-colored bars, that it would have been over the threshold for February and unusually for March. Of the 133 cases that were confirmed up to June, 46 of these were in Epi Weeks 8 to 11, around February, March, which is above the threshold for March, which is traditionally a low month. Although more cases are expected in February, 64 cases were reported in February, but 66 cases were referred in February, where the threshold is 64. So we had a slight outbreak in February and a decided outbreak in March. And we've had reports up until June, a few in July, and we have not identified any further outbreak months so far, I would have to say. So a lot of the cases are diagnosed clinically, and the case definition is usually in other countries defined as a diagnosis for travelers, but Barbados is an endemic country. So a person who has lived in an area of dengue transmission in the past 14 days, Barbados will qualify, with sudden high fever, typically of 2 to 7 days duration, and presents with 2 or more of the following manifestations, including nausea and vomiting, myalgia, arthralgia, headache, rash, petechiae, leukopenia, and then the warning signs or criterion of severe dengue, which we'll look at later. And you would recognize that these clinical findings are, some of them, close to what you'd expect for somebody presented with symptomatic COVID. without the respiratory, but nausea and vomiting, body pains, headache, and then if they're severe, respiratory signs. So the syndromes, for those that are symptomatic, we would say are dengue without warning signs, which is the slide from before. And any child presented with a sudden onset of fever with no apparent focus could also be considered a case of dengue. We are concerned for dengue with warning signs and severe dengue. Any case, and it usually tends to occur around the time of defervescence. The fever are usually, but not always, when the fever starts to go away, but the person still has or presents with severe abdominal pain or tenderness, persistent vomiting, evidence of fluid accumulation, bleeding in a child, especially lethargy or irritability, postural hypotension, and then signs. I'm not sure that we do the capillary testing to look for hematocrit progressively rising, but I've noted that persons have been asked to come back the next day for blood tests, and I'm assuming that they either want to do a clinical review or they're checking for rising hematocrit. And if there are any warning signs, you need monitoring, closer monitoring, and in our situation, referral. The severe dengue, they may present with respiratory shock or respiratory distress due to severe plasma leakage, shock, severe bleeding, including vomiting blood or a melena, breakthrough bleeding, or bleeding in the central nervous system, or severe organ compromise. The person really should be in hospital at this time because they were advised to come back if if they started to feel worse, or come back for review, so that these things could be, they would actually have the liver function test or be able to tell that there's altered mental status, and not persons presenting to A&E with severe dengue, where they may demise before anything can be done to help. The diagnosis, the laboratory diagnosis of dengue is for us from around 2018 by real-time PCR, and is by detection of the viral RNA. And on these samples, we can also determine the type. So we need an early symptomatic acute phase blood sample. In this case, the acute phase is up to day 7. A sample from day 1 to day 5, day 1 being first day of symptoms, up to day 5 of symptoms, day 7 even, to get a PCR test and type in. There's detection of the NS1 antigen, but since our protocols say that a confirmed case is still that determined by real-time PCR, we say that even though we accept it as a case, that we count those among the probables, and that NS1 antigen can be determined on an acute phase blood sample up to day 9 after symptoms. We can also detect IgM in a single serum sample from day 5 down to, I guess, 12 weeks. The IgM is present, but you wouldn't wait that long. And or a 4-fold increase in dengue virus specific antibody titers, samples collected 2 to 3 weeks apart. And because of flavivirus cross-reactivity, we do tend to say suspected or probable for those cases, but we still act whether they're suspected or probable investigations and interventions are done. So we need you to notify. So for up until 2016, 17, when the only flavivirus that we were aware of in Barbados, we tend to diagnose yellow fever. The yellow fever is not endemic. We tended to diagnose dengue virus disease based on dengue IgM. But since Zika has come on the scene, there's significant cross reactivity for the antibody testing. And the protocols say that if the sample is DenV positive and DenV and Zika negative, the most we can say that is a probable dengue virus. Similarly, if it's dengue negative but Zika positive, the most we can say is probable. And if it is positive for all two, the most we can say is a flaviviral infection. We have not seen probable, we've seen a couple of probable Zika virus recently, maybe a handful, but the majority, when we do the PCR testing on them, if they're within the timing, they've turned out to be Zika. Sorry, they've turned out to be dengue. We have not managed to isolate any positive PCR Zika for the longest time, for the year so far. And there's a triplex PCR testing. If samples come in, and the diagnosis is usually query viral illness, not even query dengue, query chickpea, query Zika, query viral illness. And the test is run, and so far the only PCR positives have been dengue. So we have been doing surveillance religiously in Barbados since about we have data from 1998 or so, 1990, yeah. The 1990s every year. And I suspect that this is, for our completeness of data, this is why we figured so highly on the global burden of disease study. One of the reasons that we figured so highly on that, those analyses. So we need your help to actually complete the surveillance. Cases are to be notified. Suspected cases, which are clinically determined, probable cases from IgM antibody or NS1 positive. The lab does, one of the labs does notify to us, but physicians, what they can't give all the information that a physician notification would give. And confirmed cases, which we get that information from our lab with the information that is sent from the attending physician. With information that is needed, the clinical diagnosis that is being queried, the address of the patient, because we have to go and look for the mosquitoes and get rid of them. Signs and symptoms, date of onset of symptoms to help determine what tests to do, date of specimen collection for the same thing, and your contact information as the attending physician if we need any more information. And dengue notifications are critical to locate the cases, the mosquitoes and mosquito breeding sites to try to abort any possible outbreak. The notifications forms, they're still the old ones because the legislation updating the need for other things or the old notification form is still being used. It can be scanned and sent by email or WhatsApp or to the two addresses that are there. They can also be sent by surface mail. And I guess in a pinch, you can also call the EPI unit, but the information that it is needed, we need actually information of the address of the patient, especially, so that we can put control measures in place. Dengue management in this time of COVID is to, well, at any time, is to reduce mortality by appropriate care, because they've recognized, WHO has certainly released updated management guidelines, and it was recognized that even with severe dengue, that mortality is reduced. And the most important thing is to determine, first, could it be dengue? In this time of COVID, we're going to need to rule out COVID. So the advice is to test for both. Test for dengue, test for COVID. Co-infection is possible. And apparently the antibody tests can cross-react, but the PCRs are not likely to be mixed up unless there's human error. The samples are different. One is blood and one is nasal swabs. And also to determine what is the stage of the disease to do appropriate management. Uncomplicated dengue without warning signs, the possibility is you advise the patient and send them home with advice, review, either sometimes they may not come back, so review, even if you have to call and ask them what is going on, and that is possible. If there are no warning signs and no complicating factors, such as age, chronic diseases, medications use that can mask anything that might, like any warning signs that might be happening. If there are warning signs, you need to stabilize and transfer for medical monitoring and intervention, because it is believed, especially with the condition of plasma leakage that can progress to shock or organ failure, that the patient just needs to be stabilized over those 24 to 48 hours in a hospital setting with appropriate monitoring. Also to see when the plasma leakage stops, so that they can be weaned off of the fluids that are being given and not demise. If there are no warning signs, but there are complicating factors, such as a very young child, seek advice to determine. I've noted that some persons are told use analgesia. I've not been in clinical medicine I've not been seeing patients for a couple of years, but I am aware of persons are told to come back for a review with a blood test. But they may not come back by themselves. They may have to be, I guess, depending on the age of the person, they may have to be actually actively followed up and or put in a situation where they can be monitored to see if they develop warning signs. This year so far, by the end of last year, remember that I had said that sometimes the first time you know that something is happening when an outbreak is occurring is when the young age group, the 5 to 9 to 15 or whatever, turn up with severe disease. And the first few that we recognized, the first 3 actually, were children that were hospitalized. If they are very young, it might be best to have admitted for observation, so that if there is a complicating factor, we've had sickle cell disease and other illnesses, that the person does not deteriorate too quickly for then to be admitted for intervention to be made. A lot of people, probably many people, may be asymptomatic but and those I guess we won't worry about at all. But the symptomatics, the purpose of intervention is to prevent or attenuate severe disease and prevent death. Now, to prevent dengue, we would like to do that. I would like that to happen. Our current strategy, for which we need your help, is that we recognize outbreaks early and intervene with removal of the mosquitoes and larvae and so on. More recently, Barbados has entered into a project with the Imperial College in the UK, and using data from Ministry of Health and Wellness, the Caribbean Institute of Meteorology and Hydrology, Barbados Met Services, with funding from the Red Cross and some other organizations to create an early warning system for dengue outbreaks, looking at climatic conditions. So with our decades of data on dengue occurrence and matching climatic data from CIMH and the temperature data from them and rainfall data, we were able to come up with a model that predicts, that match first and then predicts when dengue outbreaks are likely to occur. We've had so far, good agreement, and we actually now have to roll it out. We've recognized that because of human intervention, 2 months after rain, we've noted that after a drought and we get a lot of rain, we can expect around 2 months or so later to start to see dengue outbreaks. But we've also recognized from analysis of our data that there's a lag time with temperature and rainfall and 6 months, what we call a long lag, that we are also likely to get dengue outbreaks. So what we are doing is working now with the Met system, Barbados Meteorology Met Services, to see if we can set up an alert system when the appropriate temperature and rainfall conditions occur, that sort of like you have a haze alert. You also get a dengue alert 3 months in advance so that we could start to do the control of look for adult mosquitoes and try to get rid of them, look for breeding sites and try to get rid of them to see if we can prevent a dengue outbreak. We'll see how well that works. And because of the theoretical success, a modeling is going to be rolled out also for Jamaica and some other countries in the Caribbean. The measures that we have so far are mosquito measures, adulticides, the lot of fogging, larvicides, killing, not only destroying breeding sites, but actually killing the larvae using fish and chemical means. And also for human beings, preventing bites for the hungry females, nets, screens of buildings, repellent impregnated clothing, if actually clothing, actually covering your skin, and then using repellents. And in some countries, there have been the use of dengue vaccination. The dengue vax, I guess, is the only one so far that has come to market, but there are others that are in the pipeline. With that one, remember that there are 4 serotypes. There have been issues since it was put onto the market. They've recognized that it is best for persons that are that have had a first infection of dengue, because it can provoke, if the person is dengue naive and you vaccinate them, the next time they get dengue, it can provoke severe disease through the mechanism of antibody-dependent enhancement. The antibodies, from the first exposure from the vaccine would not be neutralizing, not so far. And the second exposure, these non-neutralizing antibodies actually help the virus into the cell. And the virus proliferates so much that it produces severe dengue. So what they recognize in the countries that are using it is that you check to make sure that persons have been exposed, look for the IgG before they are vaccinated. But they're working to try to produce a vaccine that can be used, can be used for the 4, and that is helpful even in those that are dengue naive. That has been the dengue, the virus update. And I'm sure, well, I haven't used any pictures, but you're aware of the global distribution. You should be more familiar with the patterns in Barbados or bimodal, unless we're having a really bad year. National surveillance guidelines, test. We need blood tests in the acute phase to be able to determine what the type is. So please do that for some of your clients. Notify all of them and focus on determining or identifying that small subset of persons who may have warning signs or go on to develop severe disease to be able to prevent death, and also to assist us in preventing outbreaks of the disease in Barbados. Thank you. Here are some of the references that were used. Thank you.
Thank you so much, Dr. Rollup, for a very comprehensive update on the dengue situation in Barbados. I'm going to quickly turn over to Dr. Whitney Bess for any questions that we may have. Dr. Bess, I have a few questions in the actual chat as well.
Yes, you do. Thank you, Dr. Rollup. A lot of questions, but we'll see what we can get through. From Dr. Alert, do you require both acute and convalescent sera for typing?
No, we cannot type from serum. We cannot type from the antibodies. We can only type from, I messed up your question. We can only type from acute phase when the virus is present, when we believe the virus is present. We can't type from NS1. We need virus. We need a sample that would still have viremia to be able to get the typing.
Thank you. From Dr. Shepherd, given the status of dengue, what is the role of public health inspectors? In the old day, we used to see them frequently. I have never seen any in our vicinity for at least 20 years.
Mm-hmm. The trust, since we will never have enough of the the environmental health officers, to go to every house in Barbados, what we've been trying to do is encourage the community members to inspect their premises at least once per week when the rain starts to fall, to look for breeding sites and get rid of them. And the education recently is on pointing out that even plants, certain plants, the pretty ones that hold water, can also be breeding sites for mosquitoes, and to use larvicides that would not kill the plants themselves in those, if you must have those kind of plants around. But we need community assistance to do it, because we will never have enough environmental health officers or assistants to go around to every premises in Barbados to do that.
Okay, thank you. From Dr. Grandison, are we looking for other mosquito-borne illnesses like Oropouche virus that presents to dengue? And is there any plan in place for an electronic portal or mechanism for notification?
Right now, we can test for, we can check for Mayaro at the public health laboratory as well. We would have to send samples to CARFA for Oropouche, which they check for. We check for CHIKV, we check for ZIKV here. And the other samples that are negative for everything, There are a lot of them that present. There are some encephalitides that we are not aware of here, but can occur. Those are sent off to CARFA to do testing for us. The antibody testing, I guess we can send from whenever the person shows up. From day 9, they can check for IgM. But if we're going to do if they're going to do PCR, even if they refer them to their reference lab, it would have to be an acute sample.
Thank you. From Dr. Fernan, why not do regular prevention methods every 2 months from the start of the rainy season?
People get tired, unfortunately. You may be aware that the dengue, the prevent mosquito-borne illness PSAs are run in cycles from when the rain starts. And when we can, some of the inspectors that are not going to businesses and tracking down people, also they may do some teamwork to go around the districts. So we tend to start when we expect water to collect, the general areas for, there's certain places that whenever the rain falls, you see water collect. The inspectors tend to focus on those, to throw fish, to put in fish that persons tend to fish out, to put in larvicides, the chemical larvicides, and also to do the fogging. But if we fog continually, we are likely to provoke resistance from the adult mosquitoes for continuous. So we tend to do these things in cycles. When there was the water on the South Coast at the end of 2018, I think it was, there seemed to be almost continual fogging down there because, of course, there were a lot of mosquitoes. Not all of them were Aedes. A lot of them were culex. But the risk of, if we do it continuously, that we provoke resistance in the mosquito, and that would reduce the effectiveness of that chemical method. But we do the education in cycles to try to encourage persons to go out and look and turn over and so on.
Now, just to follow up from that, the last question we'll be able to take. There's a story on how Disney in Florida has been able to get rid of the mosquitoes. Are these methods applicable here?
We have been invited to do, we have been using multiple methods for mosquito control. The Wolbachia, the infected mosquito that would go on and infect others, we've used that. The release of sterile mosquitoes, there will be a period, we've been invited to do that, but that's something that persons have to be prepared for because to increase the number of mosquitoes, or what we do with we see mosquitoes, we try to kill them. But if we release mosquitoes to try to replace our local mosquitoes with the sterile mosquitoes or the treated mosquitoes, they would have to be allowed to live to replace the other ones. So we have been, we are considering, we have been in discussions with CARFA and the Caribbean Public Health Agency about introducing other methods of mosquito control. We were actually detailed and given an opportunity to do the irradiated mosquitoes and all that. But it will take, we would have to educate our population. And because we don't have a part of the country where we can test it out, we would have to do it island-wide one time. So we would have to get cooperation from the population to do something like that. And when we are less, I guess, it's something that we are considering for the future. Let me put it that way.
Well, thank you so much, Dr. Rolla. Thank you for sticking with us, even though we're running behind time. Just to remind everyone, our next session will be on Saturday, August the 28th, when we'll be doing the management of the non-communicable disease sequelae. So we ask you to join us or look out for the email reminders of that event. Thank you so much, Dr. Rollo. Back to you, Dr. Anderson.
And I want to say what a lovely session we had this evening, even though we went a bit over time, but I am sure that all of our listeners were content with the information that certainly was provided. I wanted to say a very special thank you once again to our sponsor, Western Scientific. Without them, we would not have been able to provide this session for you. I also want to say a special thank you to all of our presenters who took the time out to provide us with very lovely presentations this evening. And certainly, I also want to extend again a welcome and thank you to Sir Rodney Williams, the Governor General of Antigua and Barbuda, for joining us, as well as some of our fraternal colleagues from Dominica, Antigua, St. Lucia, and Jamaica. Not to forget our local colleagues here. I want to tell everyone good evening and continue to be safe and enjoy the remainder of your weekend. Thank you. Good evening, everyone.